Welcome. Thank you for joining us today. My name is Janice Butchko, Senior Project Manager for the MDS Foundation, and I will be moderating today's webinar. Thank you to our sponsors, AbbVie, Bristol Myers Squibb, Gilead, Jazz Pharmaceuticals, and Taiho Oncology for supporting this webinar program. Please note this is a pre-recorded presentation, so the presenter will not be taking any questions. The live question with answer segment for all participants are included at the end of this presentation. Today's presenter is Dr. Zhuoer. Dr. Zhuoer is a hematologist and assistant member in the Moffitt Cancer Center Malignant Hematology Department in Tampa, Florida. Dr. Zhuoer completed her Hematology Oncology Fellowship training at the Mayo Clinic in Rochester, Minnesota, and Master of Science in Clinical Research at the UCLA Ronald Reagan Medical Center. She focuses on treating myeloid malignancies, including MDS and AML, with a particular interest in the precursor stages, including clonal hematopoiesis of intermediate potential and clonal cytopenia. Dr. Zhuoer's research focuses on clinical and translation science. Dr. Zhuoer hopes to identify novel therapies and clinical trials to prevent cancer at the early stage. It is my pleasure to introduce Dr. Zhuoer.
Hello, everyone. My name is Zhuoer. I'm a hematologist at the Moffitt Cancer Center, Tampa, Florida. So my clinic focus is focusing on treating patients with myeloid malignancy, such as clonal cytopenia, myelodysplasia syndrome, or leukemia. And my research focuses on the clonal hematopoiesis, or the precursor stage before patients were diagnosed with myelodysplasia syndrome or the acute leukemia. So today I'm happy to talk to you about what is clonal hematopoiesis and how do we treat such conditions. So first of all, what is clonal hematopoiesis? Clonal hematopoiesis is a normal function of aging, and it is defined as the acquisition of the mutation in the blood cells in apparently healthy individuals. Here you can see this is a chromosome structure, and basically it's structured by the DNA. And if there is a mutation in the DNA, this is something called somatic mutation or clonal hematopoiesis. So when the clone burden is more than 2%, let's say 2 of the cells, 2 out of 100 cells, they have this mutation. It is termed clonal hematopoiesis of indetermined potential. And one word, it is called a CHIP. So when the CHIP is accompanied by unexplained blood cell abnormalities, but still without other features meeting the diagnostic criteria of a malignancy, such as myeloid dysplasia syndrome or acute leukemia, this condition is called clonal cytopenia of undetermined significancy, or CCUS. So what is the prevalence of this clonal hematopoiesis or CHIP? So the prevalence of CHIP is actually pretty low in the individuals younger than 40 years old. So it's about 1%. But the prevalence rises with age, with a prevalence of more than 10% of adults aged 60 and above. And the frequency is higher for patients treated with a cancer or the individuals with a significant cardiovascular disease history. So what causes clonal hematopoiesis? So basically, clonal hematopoiesis is not a congenital condition that you are born with, but rather it is something that can occur later in the life. So who is at risk for clonal hematopoiesis? So there are actually several identified risk factors. For example, that mutation in proliferating blood cells that cannot be effectively repaired or accumulate as aging. So age is definitely a risk factor for clonal hematopoiesis. Or in the individuals who received prior chemotherapy, radiation therapy for the primary cancers. There are also other factors such as inflammations. For example, patients have autoimmune disease, for example, the rheumatoid arthritis, lupus, psoriatic arthritis, such autoimmune diseases were found to be associated with clonal hematopoiesis. And some other toxic exposures, such as cigarettes, smoking, are put patients at a higher risk for clonal hematopoiesis. So how does this clonal hematopoiesis being tested? So clonal hematopoiesis is detected during a blood test that we will use part of the blood sample for DNA sequencing. And in this figure, as you can see, there are different sequencing technologies, including whole genome sequencing, whole exome sequencing, and targeted sequencing. So for whole genome sequencing, basically they will sequence the entire genome. For the whole exome sequencing, we're only sequencing the exome. And the targeted sequencing are only sequencing the interested genes. With this different technology, they all have different sequencing depths and breadth. So the clonal hematopoiesis can be identified during other test process as well. For example, during a germline DNA evaluation, patient may be identified as with a clonal hematopoiesis. For patients being evaluated for a non-myeloid neoplasm, for example, patients being evaluated for lung cancer, breast cancer, with other sequencing tests, then clonal hematopoiesis may be identified during that process. Or the mutation may be discovered in patients with a non-neoplastic condition. For example, during a cardiovascular evaluation, for example, there are evaluations for heart condition, the clonal hematopoiesis may be identified during that process. Also, for patients with blood cell count abnormalities, during that evaluation, clonal hematopoiesis may be identified. Even in the healthy person who is undergoing a clinical trial evaluation, clonal hematopoiesis may be identified during that process. So why that is really matter? Why we are talking about the clonal hematopoiesis? So there is a growing body of the literature are showing the clonal hematopoiesis is associated with a broad impact of aging-related disease, such as cardiovascular disease, thrombosis, COPD, emphysema, autoimmune diseases, gout, kidney disease, osteoporosis, blood cancers, or Alzheimer's disease. One of the phenomena finding is that it was found that clonal hematopoiesis put patients at a higher risk for cardiovascular disease. So what are the risks for patients with clonal hematopoiesis to progress to a blood cancer? As we talk about, clonal hematopoiesis is associated with blood cancers. So only a very small subset of patients will eventually develop myelodysplasia syndrome or acute leukemia. So first of all, let's say if the clonal hematopoiesis is identified, and over the years, patient may develop some cytopenia, and then over the years may develop the MDS and acute leukemia. So what are the risk for clonal hematopoiesis to progress to acute myeloid diseases? So here is some evidence. There are several research has found that the risk for clonal hematopoiesis to progress to acute leukemia or myeloid malignancy is actually pretty low. It's less than 1% per year. So who should be tested for clonal hematopoiesis? So clonal hematopoiesis is recently identified as a new entity, and to date, there have been no guidelines for screening clonal hematopoiesis in healthy individuals. However, your medical providers can advise you to determine if there is an indication for screening for clonal hematopoiesis. So at Moffitt, we have a clinic which is called a Catch Clinic. And you can, and if you are at a risk for clonal hematopoiesis or already identified or diagnosed with clonal hematopoiesis, that you could ask your provider to refer you to our Catch Clinic. For your consideration, some of the patients are at a higher risk. This including, chronic smoker, age older than 65 years old, having a prior history of cancer-directed therapy, having an active diagnosis of cancer and planning to receive additional therapy, and a family history of myelodysplasia syndrome or leukemia, or patients have clonal cytopenia are considered as a high risk and should be referred to the clonal hematopoiesis clinic. So how does the clonal hematopoiesis clinic look like, or how is clonal hematopoiesis treated? So at this time, many institutions are creating specialized clinic on managing patients with clonal hematopoiesis. And it's really our job to help you to understand what is clonal hematopoiesis and what is the implications. And we will organize further diagnostic testing and a monitoring plan, and also refer to other necessary specialties, for example, the cardiologist or geneticist. So in light of the fact that clonal hematopoiesis is associated with multiple aging-related disease, so we are actually have a very robust collaboration with our other specialties such as cardio-oncologist, medical geneticist, rheumatologist to provide the best treatment plan for you. So the central theme of the clonal hematopoiesis clinic is focusing on optimizing the cardiovascular risk factors, including monitor the blood pressure, make sure the lipid is within the normal control, and the glucose monitoring. Also to ensure our patients is on a healthy diet, make sure the smoking, we have a discussion on the smoking cessation and weight control. So at this time, there is no standard of care regarding the frequency of the blood count monitoring or whether we need to do a bone marrow biopsy. So the clinical decision really depends on the individual clinical scenarios. And enrolling into the clinical trials or the natural history studies, including the biobank samples, are to store some samples in the biobank are very important. Well, the novel therapy have radically changed the standard paradigm of treating cancer. It is very important to reconsider some of the treatment regarding their benefit and risk. So knowing the presence of a pre-existing clonal hematopoiesis, for example, may influence the decision to whether we need to use the adjuvant chemotherapy or maintenance therapy. So at Moffitt, we are running a pilot clinical trial where we are screening patients from the oncology department. These patients including patients newly diagnosed with breast cancer or colon cancer with additional risk factors, for example, age older than 65 years old, have a very heavy smoking history, family history of blood cancer, and prior therapy who received a prior chemo or radiation therapy. So we will sequencing such patients, we provide free sequencing for such patients. And I think my goal is to assist our patients and their treating physicians with an informed discussion whether they should receive adjuvant chemotherapy, maintenance therapy, and also to guide them, what will be the best subsequent therapy if needed. So why should you come to the CATCH clinic at Moffitt for evaluation? So while patients with clonal hematopoiesis may not experience any symptoms, as we discussed, the clonal hematopoiesis was found to be associated with a variety of aging-related disease, such as the cardiovascular disease, stroke, heart attack, autoimmune disease, osteoporosis, lung disease, and kidney disease. And in addition, we talk about when the clone, the mutation size is growing, there are potential risk to progress to blood cancers. So at Moffitt, our experts, including a hematologist, precision medicine team, genetic counselors, and heart doctors, will assess every patient on an individual basis and create an individual health plan for you. Now we are going to talk about some available clinical trials. So currently there is no standard of care for patients with clonal cytopenia or clonal hematopoiesis. There is no FDA approved therapy for such condition. There are several clinical trials available currently under investigation for different therapies. So the first clinical trial is using a medicine called canakinumab in patients with clonal cytopenia. So this is an anti-inflammatory therapy with the hope to reduce inflammation and then to help with the clonal hematopoiesis status. The second medication is using the high dose of ascorbic acid or vitamin C in patients with a very specific type of clonal cytopenia, and this trial has completed accrual at this time. There are other clinical trials are using targeted therapy to target the specific mutations in patients with such condition. There are also clinical trials using metformin or statins in patients with clonal hematopoiesis or lower risk myelodysplasia syndrome. There is one study using oral vitamin C in treating patients with clonal hematopoiesis. So I encourage you to talk to your providers and to talk about the clonal hematopoiesis, and if necessary, refer you to an academic center for evaluation and to see whether clinical trials are reasonable to you. So here is my presentation. Thank you very much, and I'm happy to answer your questions.
Thank you, Dr. Zhi, for your wonderful presentation and your time today. We will now proceed to the live Q&A. Please submit your questions to Dr. Zhi through the Q&A button on the bottom menu bar. Okay. We don't have any open questions right now, but I do have some questions for you, Dr. Zhi.
Yeah, please.
If clonal hematopoiesis is considered genetic, why would a referral for genetic testing be needed?
Sorry, you got a little bit cut off for me, so I didn't hear completely.
I'm sorry.
Can you repeat that?
If clonal hematopoiesis is not considered genetic, why would a referral for genetic testing be needed?
Why it is needed? I mean, this is considered as a somatic mutation. And in order to identify this disease, then we'll run a DNA sequencing. Is that a question that you asked? Why we need to refer to genetics?
Yeah, that was just why would a referral for genetic testing be needed?
Oh, what kind of testing will be needed? Okay,
yeah.
I got it. Okay, I got it now. So the testing is basically called the myeloid next generation sequencing. So this panel, including different institutions, they have different genetic panel. Some genetic panel include 50 genetic mutations, or some other institution have more than 100 genetic mutation. So for example, at Moffitt, we have our panel include 98 genetic mutations. They are commonly seen in patients with myelodysplasia syndrome or acute myeloid leukemia. So we use this panel and to run this test, which is a DNA sequencing test, to identify what kind of genetic mutation patients have.
Okay, thank you. We have a question from Renee. I'm currently a CCUS patient and being monitored monthly with blood testing. What important questions should I be asking my hematologist?
Very nice questions. So, for CCUS, basically it means patients has a genetic mutation with cytopenia. And it really depending on what the mutations are or what the mutation is and what kind of, the severity of the cytopenia is. And then we can determine how often do we need to monitor your cell count. You mentioned that you are monitored on a monthly basis. I think it would be nice to know your genetic profile and the severity of the cytopenia, and to see, do you really need to be monitored every month, or if maybe is it feasible to do every 3 months or every 6 months? And you probably want to ask your provider about these questions. What is the best interval to monitor my cell count, and at what time point that I need a bone marrow biopsy? It's worth to talk about the specific mutation as well, to see whether this is a high risk genetic mutations, or what does it mean? What is the risk for this mutation, to progress to the myeloid malignancies? So I think those are the questions. And particularly, I think, we discussed in the presentation, patients with clonal hematopoiesis or CCUS, they are at a higher risk for cardiovascular disease. So it will be nice to talk to your either with your hematologist or with your primary care doctor regarding cardiovascular risk profiles to best monitor your blood pressure, cholesterol, and monitor your glucose, all that to make sure we reduce all the risk factors to a minimal level to make sure that patients will not develop a stroke or cardiovascular disease. So I think those are the important questions to ask your provider.
Okay, thank you. We have a question from Bruce. He wants to know if he'll get a copy of the chart of the CCUS trials and treatments.
Absolutely.
So,
absolutely.
Yes, we will provide that on our website, Bruce, within 10 business days, Dr. Xi's presentation. And he also wants to know what are the results that have been found for each of these treatments, such as vitamin C, metformin,
yeah.
Ones that are seemingly benign treatments, no chemo.
Yeah, so these are the clinical trials. So there are only one clinical trial has completed, which is the using high dose of ascorbic acid in patients with CCUS in a very specific population. This CCUS population is focused on patients with the TET2 mutation, TET2. So this trial has actually led by myself. We have already completed this trial at this time. We have enrolled 10 patients in this clinical trial. So the results will be discussed during this year, the annual American Society of Hematology annual meeting. The rest of the 6 clinical trials, they are actively enrolling. So we don't know the preliminary data at this time. For patients, you mentioned that the clinical trial using metformin is actually to repurposing the metformin, the effect of metformin in using their anti-leukemia effect. So that is quite an interesting study. So I think it's led by our colleagues in Europe. So we're actually, waiting for the results at this time. Some other studies, I listed in the clinical trial page, they are using statins, for patients, the statin is a medicine that's used in patients with high cholesterol. So they are actually using that medicine. It's not really for anti-leukemia effect, but it's more for, lower the risk of cardiovascular events. There are another 2 trials is using anti-leukemia medicine. One is called IDH1 inhibitor. The other is called IDH2 inhibitor. Both of these trials are targeting very specific patients to target the patients with IDH1 mutation and IDH2 mutations. So all of these trials are not necessarily to target all patients with clonal cytopenia, but the trials using metformin, using statins are trying to target all the patients with the CCUS, but the other trials are really targeting very specific patient population. So we'll definitely share the slides with our patient population.
Great, thank you. I have another question from Renee. What is the risk level of progression to MDS with a DNMT3A mutation?
Yeah, very nice question. So, basically, I shared in my presentation, I shared 2 large study. This is a patient population study, basically looking at a patient population. For example, one is led by the, using the UK Biobank, among, I think it's about 200,000 patient population. And they look at patients in that, they look at the risk in that patient population. What are the risks to progress to MDS or acute leukemia? So keep in mind, so those patient population are largely driven by the healthy individuals. There are only a very small subset of patients in that cohort. So in that study, it actually showed that patients with clonal hematopoiesis, the risk for progression to MDS and acute leukemia is actually very low. It's 1% per year. And basically 99% of the patients, they will not progress to MDS and the leukemia. And then talking about this very specific mutation, DNMT3A mutation. So unless it is a very high risk DNMT3A mutation, usually the R882 mutation are considered as a pathogenic and a very high risk for progress to MDS and leukemia. If patients only have an isolated DNMT3A mutation, without that, specific type, the R882 mutation, they are actually at a very low risk to progress to myeloid disease, MDS or AML. They are actually at a favorable risk. It means that compared to other mutations, patients carry this mutation at a very extremely low risk to progress to MDS and AML. Let's say if you do have these mutations, might probably, I don't know exactly the case. If this is isolated D93A mutation and your cytopenia, the severity of the cytopenia is very mild. Potentially, you could talk to your provider, maybe not necessary to monitor your cell count very, very, very closely. I think, every 3 or maybe even every 6 months, if it is stable every year, probably is good enough.
Great, thank you so much.
Mm-hmm.
We have another question from Bruce. How do I find out about trials for CCUS? I was diagnosed with CCUS. I have tattoo, LYSII3, and ASXL1. My specialist at Fred Hutch did not mention trials for CCUS. I am on a wait and see.
Yeah. So how do you find the clinical trial in CCUS? The first question is that you can go to the clinicaltrial.gov and then tap clonal cytopenia, and then you will see these clinical trials. So, the 3 mutation you mentioned, I'm not quite familiar with the second, or I didn't hear very well for the second, but I heard the TET2 and ASXL1. So one thing that I could tell is that, the more mutation patients have, a slightly higher risk compared to patients with only 1 mutation. I think it worth to consider to monitor your cell count, maybe every 3 months, just to make sure everything is stable. Once you find out, so like we discussed, that we will share the slides for the clinical trial, and then you can look at on the clinical trial.gov as well, and to maybe reach out to the investigator and whether you will be a good candidate for that trial.
Okay, great, thank you. We have another question from Renee. What steps can be taken from a diet, nutrition, and supplementation standpoint to support cytopenia?
Yeah, very good question. So you mentioned the diet and the nutrition. So first of all, in my clinic, if patient comes to me with cytopenia, I usually run a bite-off test to make sure, this cytopenia is not related to the nutrition deficiency, including, B12, folate, iron, all that. I will check all of this nutrition deficiency profiles. And let's say, if I find the patients have folate deficiency, which actually is not very common seen in the, population in the United States population, but, still there are some patients, for example, they have history of bariatric surgery or with other GI issues that they do not absorb the nutrition very well. I will run this test and I will see, if is there any nutrition deficiency. If I find that there are nutrition deficiency, then I will replace this. For example, patient has a B12 deficiency, then I will replace B12 has a folate acid deficiency, then we'll definitely replace all of this to correct their nutrition deficiency. Let's say if we run off, there's no other evidence patient has a nutrition deficiency, there's no way to improve the cell count from a nutrition perspective. So I think, like I mentioned, the folate acid, B12, and iron, those are the important elements to form the red blood cells, all of your blood cells. So these are important to test. And if this is, all of these are completely normal, I would encourage to eat, healthy diet to maintain, try to avoid, fried food, or just try to make sure that, you have a healthy diet and, maintain your activities. So maintain a good lifestyle. So this way will help you, to maintain a good shape, but not necessarily necessary to improve the cell count.
Thank you, Dr. Zhuoer. I have another question. Which specific cardiac disorders are associated with clonal hematopoiesis?
Yeah, so, actually the study has done in quite broad research. They find the coronary artery disease, heart failure, those I'm aware of are associated with the clonal hematopoiesis.
Thank you. Another question, does the allele frequency of mutation directly correlate with a person's risk of developing MDS and AML?
Yeah, perfect question. So currently there are studies shows this variant allele fraction is associated with the risk for disease progression. And what is the cutoff is need to be, it's not exactly, we know the exactly cutoff, but basically from one of the study led by myself and some other colleagues, the study showed that the variant allele fraction higher than 15% are associated with a higher risk for disease progression. On another word, on the other hand, we actually don't know whether the reduced clone burden will be benefit to reduce the risk for disease progression. This is something that under investigation. So hopefully, eventually, we have some therapy that can reduce the clone burden and to show, okay, this is a good way to reduce the disease progression. But we do find that the higher clone burden is associated with disease progression.
Okay, great, thank you.
Mm-hmm.
For stem cell transplants, are donors tested for clonal hematopoiesis? If the donor does have a CH mutation, does that impact the effectiveness of the transplant?
Yeah, this is a very, very good question. So currently there is no standard of care. It's not a standard of care to sequencing the donor, when the stem cell transplant is needed. So it's not a standard of care. Currently, it is okay to run the sequencing test in a research basis, or if there are institution guidelines to sequencing the donor. One thing that in the study is that patients with the donor with clonal hematopoiesis after the transplant, it was found that the recipient has a more risk with GVHD, graft versus host disease. This is likely reflected by the inflammation nature of the clonal hematopoiesis. So I talk about, there is no standard of care to sequencing the donor, but let's say if patients is found to have a germline mutation such as DDX41 mutation in the patients, then it is very important to sequencing the donor as well, because this is a germline mutation, and if the donor is their family member and they do have the same mutation, then after transplant, basically will transplant the germline mutation to the recipient, so it doesn't really help with the condition. So in summary, currently there's no standard of care to say, we're going to sequencing the donor. But let's say if there is a high risk of germline mutation, then sequencing the donor is needed.
Okay, great, thank you. Mm-hmm. And Bruce wants to know if the foundation has a list of doctors that specializes in CCUS. And we do have our centers of excellence, Bruce, of doctors that specialize in MDS, and I'm sure there's plenty on there that do specialize in CCUS. So we can reach out to you and get you in touch with somebody if you want to give us a call. And he just said that his oncologist specializes in MDS, yet told him that he does not have MDS, but diagnosed with CCUS. And he would like to consult with a doctor who specializes in CCUS.
Yeah, for sure.
So, Bruce, yeah, if you want to reach out to us, we'll be happy to help. And I have another question here for you. Is a CHIP diagnosis considered a pre-existing medical condition with insurance companies?
Yes, so good question. So before 2022, it is not considered as a medical condition. But after 2022, we do have an ICD code for CHIP and the CCUS. So the insurance should consider this is a medical disease or, a precursor stage. And the insurance should cover, if patients is needing a sequencing test, then it definitely the insurance should cover this.
Okay, great, thank you.
Mm-hmm.
And as there is no ICD code for clonal hematopoiesis, is insurance financial burden a barrier for monitoring patients with clonal hematopoiesis?
Like I said, there is an ICD code after 2022, so the insurance shouldn't be a financial burden to continue to monitor patients with clonal hematopoiesis. One thing is that the insurance would not cover the sequencing test if patients, generally is healthy, they want to do a sequencing test. In this condition, CHIP is not identified yet, so the insurance wouldn't cover this condition. But let's say clonal hematopoiesis is identified in whatever way. For example, maybe during a cardiovascular exam, clonal hematopoiesis is identified. Then once the clonal hematopoiesis is identified, then patient will have an ICD code for that diagnosis, and the insurance should cover, and then there should not be a financial burden. I just want to give a shout out to our clonal hematopoiesis clinic at Moffitt. So we are running a clonal hematopoiesis clinic, and then for patients with breast cancer, colon cancer, and neuroendocrine tumor, all of the three tumor newly diagnosed and with a higher risk, for example, patients is older than 65 or has a long history of smoking or have family history of leukemia, then we run free sequencing tests for such patients and trying to help them to make a decision down the road whether they need to receive more cancer-directed therapy, the best therapy for them. So we're running this test for free. So in the future, we are hoping to get more patients population. Currently, we are only focusing on these three diseases, but down the road, hopefully we can get it larger and sequencing can do more sequencing to our population.
Great, thank you, Dr. Zhuoer.
Yeah.
Another question from Renee. What does a low cellularity for age, 30%, age 45 mean in terms of general health, risk of progression to blood diseases or other conditions?
Yeah, good question. So how do we calculate the cellularity? Is basically everybody has different cellularities, like bone marrow cellularities. Basically, how do we calculate a normal cellularity for you is use 100 minus your age. For example, a patient is 70 years old, then the 30% of the cellularity is a normal cellularity for this patient. But if I say another patient is 60 years old, then the 40% of the cellularity is their normal cellularity. So everybody has different cellularities. As we are just born, like the babies, they have 100% of the cellularity. All of their bone marrow are fully occupied by the cells to, the hematopoietic, stem cells are producing a lot of cells. So as we're aging, we have less cells. So everybody has different cellularities. There's no study really say, okay, the cellularity is, what is the number of the cellularity is indicates a risk for progression because everybody's cellularity is so different. But we do know that, let's say, the 30% is the normal cellularity for a 70 years old patients. But let's say if this patient has only 10% of the cellularity, perhaps this patient has has pretty severe low cell count. Is because just we know that there's not much cells in the bone marrow, the factory of your body. Perhaps wouldn't be able to produce a lot of cells. There is an association, like hypocellularity is associated with the severity of the cytopenia, but not necessary to say it's going to progress to the MDS or leukemia.
Thank you, Dr. Zhuoer.
Mm-hmm.
And I have a question from Hasu. Wants to know what criteria definitely identify CCUS as against MDS.
Yeah, so basically the differences between the CCUS and MDS is basically from the bone marrow biopsy. We do need a bone marrow biopsy to confirm there is no disease of myelodysplasia syndrome. So when we look at the bone marrow, then we look at what is the percentage of the dysplasia. So what does the dysplasia mean? That when we do the bone marrow biopsy, there are two parts. First part is the aspiration, and the second part is core biopsy. The aspiration, just like we draw a tube of blood from the bone marrow, just like we draw your blood from the peripheral veins. So when we draw this blood, then we put it on the slides and we look at, okay, what is the shape of the cells? And if the cells doesn't look like very healthy, then we call it dysplasia. So once the percentage of the dysplasia is more than 10%, we do know, okay, this is MDS. But if there's not a lot of dysplasia, just a little bit, we can't really tell. But also with the clonality means that patient may have some mutations in this condition, This is called the clonal hematopoiesis. And on top of that, in patients with cytopenia, this condition is termed clonal cytopenia. So the main differences between the CCUS and MDS is the dysplasia.
Great, thank you.
Mm-hmm.
We have another question from Hasu. What is the relationship between CCUS and blast?
Yes. So in CCUS, usually we do not see blast. A blast is premature cancer cells. Let's say a patient may be with a very low blast, but without the dysplasia, they can be considered as CCUS. But let's say if once the blast is more than 5%, then this will be considered as MDS with low blast. Especially in that condition, most of the patient will have dysplasia. So once again, I think the major differences between the CCUS and the MDS. I don't really see a lot of patients with CCUS and they have tons of blasts. Usually, for MDS will be considered 20% of the blast will be considered MDS, and more than 20% will be considered as acute leukemia. I don't usually see patients with CCUS with a lot of blasts that will be considered as MDS. If it's less than 5% without dysplasia, it's possible that this condition, that condition is CCUS.
Thank you, Dr. J.
Mm-hmm.
Another question from Bruce.
Mm-hmm.
What are the known causes of CCUS? Bruce went through chemotherapy for stage 3 lymphoma, which is in remission. At 6 months after chemo, his blood counts dropped. Can chemo be a cause of CCUS? His blood counts were normal prior to chemo.
Yeah, the chemotherapy, let me first answer what are the known causes can cause CCUS or clonal hematopoiesis. First is age. We do know that clonal hematopoiesis is very rare in patients with younger than 40 years old. But once the age is probably or 65, we do know the prevalence is increasing with age. Smoking is definitely another risk factors. You do mention that the chemotherapy or the radiation therapy, that we do see that patients after the chemotherapy that can is very hard to say, the clone, depending on what kind of mutations that you have. Let's say if it is, there are age-related clonal hematopoiesis such as DNMT3A, PET2, ASS1, those are age-related. But let's say there are TP53, there are PPM1D mutations, they are likely related to the chemo radiation therapy. So depending on different mutations, we can, we can tell whether it is a chemotherapy related or not. There is another condition. Patient may already have the TP53 mutation at baseline, for example, even before the lymphoma diagnosis, but it's at a very low, at a very minimal level. We don't even with the current technology, we may not even to detect this mutation. But after the chemotherapy, that we do know chemotherapy can select some of this mutation to grow further. For example, in my practice, I do have a bunch of patients who received the chemo and the radiation therapy, and after that, we do see the TP53 and PPM1D mutation has grown, even further. So, depending on what kind of mutations it is, and we can decide whether it's a chemo related, whether it's a causality or it's just, select some of the mutations already pre-exist.
Great, thank you. And another question says, do all autoimmune disorders increase your risk for a clonal hematopoiesis mutation? Are there certain autoimmune disorders that would put you at greater risk?
Yeah, this is a very, very good question. So, it really depends on the inflammation status. Let's say patients has a hypothyroidism. This condition is autoimmune diseases, but usually not really related to clonal hematopoiesis. But let's say another patients with rheumatoid arthritis, we do know if the rheumatoid arthritis is not very well controlled and the patient has a lot of inflammation. So the clonal hematopoiesis is related to the inflammation. The inflammation can trigger the growth of the clonal hematopoiesis. So not really necessarily a very specific type of the autoimmune diseases, but basically depending, the inflammation level. If the higher inflammation level, there will be a greater chance, be associated with the clonal hematopoiesis.
Great, thank you.
Mhm.
If anybody has any more questions they would like to submit to Dr. G, please submit them through the Q&A button on the bottom of this menu bar on your screen. I have another question from Hasu. What are the typical symptoms of CCUS compared to MDS?
Mhm. Yeah, so first of all, why we are calling it is MDS, it's myelodysplasia syndrome. So the syndrome mainly means that this is the bunch of symptoms. So for MDS, patients usually presented with anemia, with thrombocytopenia, low platelet count, and with low white blood cell count. Usually the presentation for MDS is patient, let's say patient has anemia, then patient may present with like fatigue, really tired, short of breath. If they have low white blood cell count, that they are at a really high risk for infection, they may present it with neutropenic fever. With the platelet, I do see our patients, the skin are quite, frail and then, with a lot of bruises. So that's why the MDS is called is myelodysplasia syndrome, just because of patients with a bunch of symptoms due to the cytopenia. Comparing to MDS, for CCUS patients, usually the severity of the cytopenia is not as severe as MDS. So usually patients with CCUS, they don't usually have a lot of symptoms unless they are blood transfusion dependent. They may feel tired, they may feel short of breath, but most of our patients, their symptoms is actually pretty minimal, unless, it really depends on the severity of their cytopenia.
Great, thank you.
Mm-hmm.
And we have no further questions. Does anybody else have any other questions for Dr. G? Okay. I think that's all the questions we have for today, Dr. G. I would like to thank you so much for your wonderful presentation and your time today.
And it's my pleasure too. Yeah.
Thank you so much.
Mm-hmm.
And this Dr. G's presentation will be available on the MDS Foundation website for on-demand viewing within 10 business days. We appreciate your feedback, so please see the link in the Q&A function to fill out a survey to let us know how we are doing. And you can find that on your screen right now to click the link to the webinar chat. And if you have any questions that went unanswered, please email me at jbutchko@mds-foundation.org. Also, you will see the QR code on the screen right now. You can, that will take you to our survey. Please fill it out to let us know how we are doing. We will appreciate your feedback. So this concludes our presentation for today. On behalf of the MDS Foundation, thank you for joining us. Have a good day.
Bye-bye.